And now I'd like to introduce you to our last panelist, Dr. Carolyn Langer, who is not unfamiliar to Regis College. She has been a great advocate and also very involved with this health lecture series over the years. Dr. Langer is a physician, a judge, and has her master's in public health. A lawyer. Sorry, that's judge too. She's the chief medical officer from the Massachusetts and the Massachusetts Health Director for the Office of Clinical Affairs at the University of Massachusetts Medical School, Commonwealth Medicine. Welcome, Dr. Langer.
Thank you. It's a pleasure to be here. So I just joined MassHealth 6 months ago. Prior to that, I had been in the commercial sector. And it's really been a fascinating ride for me in these 6 months because there's so much innovation. And I'm really proud to be part of an administration that is really on the cutting edge of healthcare reform and really pushing the needle on health policy. So I'm going to be talking tonight about the Massachusetts Primary Care Payment Reform Initiative, which is one of the newest initiatives. And in fact, although I'm not a practicing attorney, I will make one disclaimer. During the Q&A session, we just released the RFA for this initiative, so we're going through a procurement now. So that may limit my ability to respond to certain questions, but I'll certainly try to be helpful and answer as many questions as I can. So many of you are healthcare providers, and for those of you who aren't healthcare providers, you certainly have been patients or have had family members who have been patients. So I don't think you need me to tell you how broken the healthcare system is. And I won't go through all of this, but these are just some examples of probably things you've seen in your practices that are really problematic with our current healthcare system that we're hoping that we can address with the new Primary Care Payment Reform Initiative. And I'm sure that many of you can add more items to this list as well. So the Primary Care Payment Reform Initiative was embarked upon in order to help improve many of these issues that I just put up in the previous slide, and many of the problems that the previous speakers cited as well. So primarily improving access, patient experience, quality, and efficiency through a medical home type model that puts a particular emphasis on care management and care coordination, and in particular a heavy emphasis on integration of behavioral health. And one of the things that really struck me about this new model, more so than any other pilot or other care delivery model that you've heard some of the previous speakers mention or that you might be familiar with, is the real thrust on integrating behavioral health. And it's really important in the Primary Care Payment Reform Initiative for us to incorporate behavioral health. You know that behavioral health is often treated as something separate over there, in many cases carved out. And we felt that we couldn't truly achieve integrated care unless we pulled behavioral health back into the primary care setting and really ensured true coordination and true integration. And I'll be giving some specific examples of that shortly. So we, as I said, believe that primary care is important in improving quality and efficiency while preserving access, primarily through this patient-centered medical home, again, with a heavy emphasis on integration of behavioral health services. The payment mechanism that we're going to be using to support this delivery model is somewhat novel. It is going to involve a global payment that we're calling the comprehensive primary care payment, along with a potential to earn some shared savings as well as some quality incentives. And I'll be elaborating on that in more detail shortly. So this program is going to span the MassHealth managed care lives across the MassHealth health plan, which is called the Primary Care Clinician Plan, or the PCC plan, as well as the 5 Medicaid managed care organizations. So those 5, you're probably familiar with a number of those: Neighborhood Health Plan, Network Health, BMC HealthNet, Fallon Community Health Plan, and Health New England. Together, these 6 plans constitute about 1.3 million members, and we expect to gain a couple 100,000 more through some of the ACA implementation you heard about earlier. So that's quite a bit of muscle for MassHealth to exert, and we are truly hoping that this will be transformational. We actually have a very aggressive timeline, and by the way, this model is being rolled out as a mandate under Chapter 224, which you just heard a little bit about previously. Under Chapter 224, MassHealth is required to implement new payment reform models to place patients in some sort of alternative care delivery system. And so we've chosen to enact the provisions of Chapter 224 through this novel primary care payment reform initiative. So our timeline, as I said, is extremely aggressive. By this summer, we have to have 25% of all MassHealth members enrolled in this alternative payment model. By the summer of 2014, we have to have a total of 50% of all MassHealth members enrolled in the primary care payment reform initiative. And then by the summer of 2014, fully 80% of our MassHealth members have to be enrolled in this alternative payment structure. So very aggressive timeline. So let me go into a little bit more detail about the specific payment structure. I mentioned that at the core, we have a comprehensive primary care payment. So you can think of this as a capitated payment, but I hate using the word capitation because it conjures up the HMOs of the 1980s and 90s. This is going to be a risk-adjusted payment to account for the severity of patients in a particular practice. And there will also be options for higher payments for practices that want to assume some basic behavioral health services. This particular model is being offered only to primary care clinicians, and the bundle itself is based on traditional primary care services that a primary care practice would render. In addition, it is also intended to have some add-on payments to account for all of those non-billable services that primary care providers do on a daily basis but don't get rewarded for. So for example, those telephone consultations, the care coordination, managing transitions of care, in some cases doing home visits. And I'm going to talk a little bit more about that also shortly. The second type of payment that practices will be eligible for is a quality incentive payment for attaining certain quality measures. And then the third type of payment is a shared savings payment. So primary care providers can benefit from shared savings on savings in the non-primary care services. So in other words, on specialty services, to the extent that savings are attained, and this is going to primarily involve hospital costs as well as specialist services. But to the extent that these practices can attain savings in specialty costs, they will be able to share in those savings. So let me go into a little bit more detail specifically on what is included in the comprehensive primary care payment. So as I mentioned before, it covers all of the services that a primary care practice would have traditionally billed for, such as your E&M visits. So well visits and sick visits. In addition, though, it's going to cover all of those services that, as I mentioned before, primary care practices already do on a daily basis but don't get rewarded for. So these would include things, as I cited before, like care coordination, care management, coordinating with specialists, medication reconciliation, managing transitions of care, etc. And then 3 levels of behavioral health services will be promoted with this model. At the most basic level, the Tier 1 model, primary care practices can provide some very basic care management and care coordination with behavioral health specialists. It's also assumed here that as part of this Tier 1 model, there will be a bidirectional flow of information and frequent communication with the behavioral health providers. At the Tier 2 level, practices will, if they opt for this level, would have the option of receiving a higher level of payment to provide some very basic behavioral health services. And typically these would be provided by a master's level, so perhaps a master's in nursing or a master's in social work. Again, some very basic behavioral health services. This might include certain types of screening. So for example, in an adult or adolescent population, doing some drug and alcohol screening. In a pediatrics population, doing some developmental screening, doing other types of mental health assessments, crisis intervention. and then referral to a behavioral health specialist in coordination with those specialists. In addition, it's not listed here, but one of the other areas that we anticipate this master's level individual will do is work on lifestyle management issues. So addressing some of the medical conditions that might be exacerbated by not necessarily behavioral health conditions, but that where behavioral health interventions might be successful. So for example, assisting patients with smoking cessation or with obesity management. And then at Tier 3, the highest level for behavioral health integration, practices would be eligible for the highest level of payment by providing some very definitive behavioral health services. These typically would be provided by a master's or doctoral level behavioral health specialist, and it's anticipated that they would do some evaluation and assessment of patients, some medication management, some basic therapy. So in terms of the first type of payment, the global payment or the comprehensive primary care payment, what is the purpose of this payment? So we really want to move away from the fee-for-service system where providers are incented to provide volume and not value. And one of our goals is to really have them think about the total care of the patient as well as their total population. So the goal of this type of payment structure is to not only have them focus on the patients who come in who are sick, but also to look at their entire patient panel and address the needs of patients who don't ever come in, so managing populations as well. One of the beauties of this model, I think, is that it gives a lot of flexibility to the practices. We recognize that practices are at many different levels, so some of you may be familiar with the NCQA accreditation for patient-centered medical homes. And there are practices that might be at the most basic level, perhaps level 1 accreditation, and there may be other practices that are more fully evolved with the medical home model. So for example, may have level 3 accreditation. And so we don't necessarily want to apply a cookie cutter or one-size-fits-all approach. And therefore, we've designed this payment to give a lot of flexibility to the primary care practices to use these global payments in ways that they see fit that best suit their particular patient population. So for some practices, they may use these, a portion of this global payment to build up the infrastructure of their care management team, or to invest in health information technology, or perhaps to invest more in data analytics capabilities. This particular model does, therefore, cater to a wide variety of primary care practices of all types and sizes. And I'm going to actually run you through some examples of what typical practices might look like under these 3 tiers. Again, our model provides significant incentives and financial support for behavioral health integration by encouraging practices and incenting them to incorporate and in some cases co-locate behavioral health services on site. It also ensures support and access for high-risk members through risk adjustment. So our model does also factor in that certain practices, just by nature of where they're located or the demographics they serve, just may have sicker populations. So this is just another way of showing the 3 different behavioral health tiers. Tier 1, as I mentioned before, is just the most basic level of behavioral health integration. And this typically would not involve hiring any new staff or specifically hiring behavioral health staff. We believe that these services can be carried out by the primary care practice. So as I said before, this includes a focus on care management and care coordination with behavioral health specialists. So, so no fee-for-service billable services. What that means is that these practices would not be providing any additional services beyond what is in their primary care bundle. Tier 2, as I said before, typically would involve a master's, and some exceptions, bachelor's level professionals who are doing some very brief focused interventions such as the screenings and assessments and triage. And then Tier 3 is the most intense level of behavioral health integration. So there are several models by which practices may integrate behavioral health And again, we are trying to take a flexible approach because we recognize that it may not be practical for all practices to have a behavioral health specialist on site. So we do allow for a couple of different models. In one case, the practice might have behavioral health resources that are not co-located but that are coordinated. So for example, having formalized agreements with certain behavioral health practices to allow access for their patients to the behavioral health practices at a separate location. Again, as I mentioned before, we would expect these agreements to codify that there would be a formal information exchange, a bidirectional exchange of information. And that is something that traditionally has been very, very challenging because it's, for those of you who have worked in primary care practices, it's often extremely difficult to get much information related to behavioral health treatment from behavioral health specialists. The second type of model would involve co-location, where behavioral health specialists may be co-located on-site with the primary care practice either a couple of days a week or 5 days a week. And these services would be accessed by referral from the primary care practice to the on-site behavioral health specialist. Now, co-location doesn't necessarily imply full integration, but at the highest level, we would expect full integration between behavioral health and primary care. And for these, for full integration, while it's not necessarily mandatory, we do feel that it's preferable for these resources to be co-located on site, and for the primary care providers and the behavioral health specialists to actually be working side by side as part of a joint care team. So here's an example of what a practice might look like at the Tier 1 level. This might involve a multi-physician group of primary care providers, such as internists and family practitioners and nurse practitioners, in this particular case, primarily serving an adult population. So they're capable of providing all the basic primary care services that are included in the bundle, and then they would bill fee-for-service for other types of services provided. So in other words, some practices may have additional services that are provided on site, such as performing certain types of diagnostic testing. Some of them might have imaging study capability or other types of services that may not be typically found in every primary care practice. And again, just to run through this briefly, this type of practice could achieve behavioral health integration through a number of mechanisms: timely access to behavioral health crisis screening and triage and services, timely referral to behavioral health services and following up with the patients and the practices to ensure that the patients actually kept their appointments, contact and consultation with other providers, including behavioral health specialists. And importantly, and I don't want to underestimate the value also of the need for primary care practices to really be cognizant of the resources within their community and ensure that they're referring patients to community resources, which are so important. In Tier 2, again, I'm not going to go through all this in detail, but this might be a community health center that has a full range of primary care providers plus a master's level professional on site, providing a full range of some focused behavioral health services and significant integration. And then in Tier 3, the highest level of integration, having actually a psychiatrist or psychologist or other behavioral health professional integrated with that team. The second type of payment I cited before was a quality incentive payment, and this is in some respects similar to pay-for-performance programs that exist within other payment structures. So we've developed a set of quality metrics, which I'm happy to address during the Q&A, that practices must attain in order to have access to both the quality payments as well as the shared savings. And I'm just going to skip this for the sake of time. We recognize, as I think Dr. Lindsay alluded to, this is going to be a tremendous paradigm shift for many practices. I know when I trained in medical school, I was taught that as the physician, you are the captain of the ship, and you treat one patient at a time. We didn't work in teams when I went to medical school or when I went through medical training. And this is going to be quite a transformation for many healthcare providers to be part of a collaborative care team where the physician has to give up some autonomy and some power. But at the end of the day, we think that the physicians will actually be very, very satisfied with this model because they can then focus on the complex patients and not spend as much time on services that frankly don't necessarily require an MD. So we do recognize though that we need to provide some support beyond financial support to affect this transformation, and we're going to do that through several avenues, including having learning collaboratives as well as providing some robust reporting and data to the practices. Just in terms of member protection, I think it's important to highlight that there are a number of ways that we're ensuring and reassuring patients that this is not revisiting capitation as we had in the 80s. And so patients will have a choice of primary care clinicians. They are free to switch primary care practices at any time. Also importantly, the patient experience survey is going to be a significant measure for us in this model and will actually feed into the quality incentive payments and the shared savings payments. In addition, we are placing some notification requirements on the providers to communicate to patients about their participation in this program and what the implications might be for the patients. So in terms of next steps, as I mentioned, we've already launched the RFA earlier this month. Final applications are going to be due from the primary care practices that want to participate in this model by the end of April. We will be selecting the primary care practices in May and then going live with this model on August 1st. If you are interested in this, please feel free to go to our website. There's information there, and the RFA is actually posted, as well as a procurement officer who is serving as our point of contact for specific questions about the RFA and the primary care payment reform initiative. So I know that was a lot in 20 minutes, but again, I'm happy to respond to questions at the Q&A. Thank you.
Thank you so much, Carolyn.